Said, please welcome Dr. Yvette Pyne.
This is Abigail Delaney. She's a 49-year-old mother of 3. Children are aged 16, 14 and 11, and she lives here in Knowle in Bristol. She likes Pilates classes, she knits little blankets for premature babies at Southmead Hospital, and on Thursday night she likes to go out for a glass of Prosecco with her friends. She works as an HR manager at a local financial services. She does a compressed week. I first met Abigail in December 2023, and she had not had a good year. In fact, it had been pretty awful. Her mother was increasingly frail, and she was having to get more and more involved in her care. Her middle child had started to be bullied at school, and perhaps worse of all, her relationship with her husband had deteriorated so much they were starting divorce proceedings. How do I know so much about Abigail? No, she's not a friend of mine. She could be a patient, but actually, let's be clear, she's not one of my patients. She's an amalgamation of a lot of my patients. She's not a real person. And this is an AI-generated image. Before 2023, Abby had barely ever gone to her doctor. And yet it felt like for a year or even more than that, she was coming to see them almost every month. One time she'd feel tired or she'd be struggling to sleep. Another time she'd go with aches and pains that she was really worried about. One time she even went to a doctor and confided to him that she thought she might be suffering from early onset dementia. She was struggling to think straight, her memory had started to go. She'd had a battery of blood tests, she'd filled in a lot of questionnaires, she'd even gone to hospital to have expensive nerve conduction studies and a scan of her head. None of these tests had shown anything useful in their results, and she was left feeling lost, frustrated, and a burden on the increasingly cash-strapped NHS. Her doctors weren't feeling any better about it either. They were frustrated that they couldn't give her an answer. Most of them were kind and supportive. A few of them were actively dismissive and rude. She told me she was thinking about putting a complaint in, but she was just so tired. So as you probably guessed from my introduction and my specialist interest, I suspected that Abby's condition might be perimenopause, and that might explain her symptoms. Perimenopause can affect anyone who experiences menopause. So, mostly women, but also some trans men, non-binary people, and other gender-diverse people. I think it's really important to remember that we have menopause and perimenopause, and they are different things. Most people haven't heard of that. Most people haven't heard of perimenopause. Why, given the fact that half the people in the world, half the people in this room, either have experienced or will experience menopause, do we know so little about it? Here's a quick explainer. Menopause is the point where your periods stop. And unless it's very early, unless you're very young, or we've given you medications that cause you to go through menopause, or you've had surgery that causes you to go through menopause, it's not normally something you go to your GP about. As the media is very keen to point out, it's a normal part of aging. Perimenopause, however, can be a huge source of distress, both for the person experiencing it and the people around them. Different cultures around the world focus on it to different extents and have different primary symptoms that they'll think about. Here in the UK, the symptoms most people have heard of are hot flushes. Our guidelines talk about them, and they also talk about change in periods being an important part of a perimenopause diagnosis. One of the problems of using change in periods as a key diagnostic tool is the fact that actually we think conservatively around 1 in 10 women have always had irregular periods. We also know around a quarter of women are taking hormonal contraception, which means that they don't experience periods in the way that they could be able to be used as irregular periods. On top of that, there's a lot of other symptoms that people might not know about. It has a big impact on your brain. It can make you feel tired. It can make you feel irritable, anxious, angry, depressed. It can be difficult to remember things, or you can get what some people call brain fog. It has physical symptoms as well. It can give you muscle aches and pains. It can give you things called vaginal symptoms, such as vaginal dryness, or symptoms of a UTI or thrush. Huge breadth of symptoms that don't always come all at once, and so often get diagnosed as different things as people present with them separately. Misdiagnosis is a significant problem. I've had women in my clinic crying because they feel they've lost years of their life being tried on this antidepressant or that painkiller that just weren't working. And in the meantime, their relationships were deteriorating and their work was suffering. Frustratingly as well, there is actually a really effective treatment if we can diagnose it properly. We have hormone replacement therapy, where we put back estrogen and sometimes progesterone and testosterone to help with symptoms. And for those women where HRT isn't appropriate, there are other options available as well. So you can imagine it's very upsetting when I meet people like Abby who've not been diagnosed earlier and have been suffering as a result. So I've told you a little bit about Abby. I'll tell you a little bit about myself. I wasn't always a GP. I used to work in computing. I was there right at the start of the publicly available internet. One of my earliest jobs was working for an internet provider. We'd send out little floppy disks. People would collect them in the post, put them into their desktop computer, connect via their landline phone line, up to the internet with a modem at speeds 3,000 times slower than your mobile phone is connecting to the internet today. I saw the introduction of mobile phones. I saw those mobile phones become smartphones. And I'm now witnessing the burgeoning revolution that is artificial intelligence. I've seen the way that technology can connect people in ways even a generation ago we couldn't even imagine. And I've also seen technology disrupt that deep, nuanced human connection. Much like in a GP practice, I find that desktop computers can be both a huge and important source of information, but also disrupts that connection with a patient. It becomes this third entity in the room that the doctor's paying attention to, rather than paying attention to the person in the room. What if things could be different? What, instead of being a disruption to that communication connection, it could actually help the doctor? What if it could listen into the consultation, make notes on behalf of the doctor, and then also possibly even suggest a diagnosis for the patient? Arguably, it has all the information it needs. It's got all of the notes from previous consultations. It's got all her investigations. It's got the medications she's tried that hasn't worked. And it's got access to all of the guidelines and all of the latest evidence-based research available on the internet. We talk about artificial intelligence, and what we really mean is machine learning. So the machines or computers are learning. They're learning from vast data sets that we give them to find patterns that perhaps the human eye can't see. Within AI in healthcare and research, the focus so far has been on diagnosing breast cancer, for example, or reading ECGs, heart tracings. So why hasn't it been used in primary care yet? I saw a few people bristling at the idea that there was that coming up with the computer listening into the consultation might be something you're not too keen on. When we think of the GP surgery room, we quite often share really very private and personal information in those spaces, and we need to be able to trust that the machine will also keep that safe. And I think this is probably the key reason why we've not started to introduce this in primary care so far. Why should we trust these big organisations that are developing these tools with our information? Well, first of all, there is a lot of legislation and guidelines around patient security that's really, really relevant and always used, well, mostly used. I think it's also worth remembering that actually your phone is listening into your GP consultation all the time you are there. So it's worth just having a think about that. We've talked about data privacy and data security. The flip side of that is data access. Because of all these understandable rules around patient information, we don't, as researchers, have access to the vast size of data set that we need to be able to train these systems. There's a reason why a lot of research so far has focused on images and numbers. It's a lot easier to anonymize those than it is to anonymize the written notes or the conversations that people have in a GP practice. When we think about data quantity, we also need to think about data quality. We know that data sets that do exist are biased. They're biased in the same way that society is biased. They tend to be racist, sexist, and have all sorts of other hidden elements in them, whereby the people that are currently being unheard and underserved by healthcare are the people that are least showing up in these data sets. And we need to be really careful if we start to use these data sets to build these algorithms, that we aren't at a much larger scale taking forward these biases. Specifically in association with perimenopause, we don't have a gold standard test for it at the moment. So a gold standard test is where we can definitively diagnose a condition. It's not only important to diagnose that condition, it's important to be able to compare other tests to it and to make sure that they can also diagnose it. And it's also really important because we need to be able to tell the machines whether they got it right or wrong as they're learning. So why don't we have a gold standard test for something that affects so many people? I would argue that is based on the hopefully increasingly historic element of lack of funding into women's health research. Did you know, for example, that Viagra was actually found on a small study to be really effective for period pain? No, not heard of that? No, probably not. Because the people that did that study tried to get funding for a bigger study, and they were told, oh, well, I'm not sure how relevant that is. I'm not sure it's that common. And I would argue, well, around 1 to 25% of the population experience erectile dysfunction, and around 8 to 45% of the population experience period pain. So not sure which is the more common condition there. And that, I think, is part of the bigger problem around women's health and women's health research and women's health in clinical work. We need to be breaking the taboo and having those conversations, and we need to be funding that research, and we need to be doing it now. I presented a lot of problems and lots of issues associated with my idea of an AI-assisted diagnosis of perimenopause. But I do believe it can and will be a reality. And just think, if it were a reality, how might things have been different for Abby? Perhaps she would have been less tired, less irritable. She would have been able to patch things up with her husband. Perhaps time at work would have been less tense, and she would have been getting on better with her boss. Perhaps they're all out there having a glass of Prosecco right now as we speak. So what can I give you to take away this evening? First of all, I need you to spread the word about perimenopause. Talk to your friends, talk to your family, talk in your workplace about what it is, how it affects people, and listen to people when they tell you those stories. Look at your own biases. Think about people that perhaps you're not listening to or you're not believing because they don't look or sound like you. And finally, please fight for the healthcare service that we deserve and the research that underpins that healthcare and research that is equitable and fair for everyone. I truly believe that if we can solve the problem of AI-assisted diagnosis of perimenopause, we will have started to address a lot of other human, technological, and societal issues associated with perimenopause, and more widely in society. I would like to think that the solution would be something that connects things, connects symptoms to a diagnosis, connects a diagnosis to a person, connects that person to their doctor. A human connection, which after all is what it's all about. Thank you.